Hello everybody, I am Dr. Neharika from Department of Oral Pathology. Today we are going to discuss about fungal infections of oral cavity. In detail we will be speaking about today candidiasis. So coming to the fungal infections are fungi comes from many species. There will be various species of fungal organisms with wide spread of disease, and these were discovered much before than bacteria, like around 18 centuries. And the most clinical relevance was stated mostly from many second half of many the 20th century, and it had a major source of many morbidity and mortality nowadays. And there is also increase in this fungal infection mostly because there is a advancement in the medicine. So mostly people who are suffering or taking broad spectrum antibiotics, radiation, cytotoxic drugs, immunosuppressive agents, and who are having advanced stages of cancer, leukemia, lymphoma, and certain immunodeficiency disorders are mostly vulnerable to these fungal infections. Coming to the main pathogenicity of the fungal organisms, these fungal organisms have a certain ability to adhere to host tissues and processes what normally the patient wear in oral cavity and to form biofilms. These have certain ability to form hyphae to help in tissue invasion from one part of an oral cavity to other part, and because of their ability to grow even in 37 degrees of centigrade, that is called as thermotolerance, they can grow in any environment. And production of certain organisms or certain enzymes such as many phospholipases, proteases, elastases, they help in many tissue destruction, which help in many progression of this fungal disease. So coming to classification of fungal infections, these are classified as superficial and many deep mycosis. Now, superficial mycosis all comes under the skin disorders. We are mostly concentrating on the oral fungal infections, which is most important is candidiasis. So candidiasis, histoplasmosis, blastomycosis, paracoccidiomycosis, coccidiomycosis, cryptococcosis, zygomycosis, aspergillosis, sporocricosis, and rhinosporosis, all this comes under the fungal infections of the oral cavity. Now, as we have discussed before, we are going to discuss in detail about candidiasis. Candidiasis had many varied amount of terms. One of the term is moniliasis. Nowadays it is discouraged because it's used from very long term. The main name of the candidiasis is either it is used as candidiosis or many candidiasis. Obviously, because it is mainly caused by candida, is called as candidiasis. It is also called as oral thrush because the thrush means also called as many diseased bird. So it's a most common form of many fungal infection. It typically infects other than oral cavity, skin, nails, mucous membranes, GIT, also internal organs. If it is mainly affects all parts of the body, and it caused by the species Candida, and there are around more than 150 species of Candida. Candida albicans is the most opportunistic infection we see in the oral cavity, and that's the reason why it is called as disease of disease. That is, it is mainly caused by the disease. When the person is suffering from the disease, it is mainly causes the disease. And the reason for it is also seen in many healthy individuals due to immunosuppressive agents. So coming to the species, it is caused by many Candida albicans. The name Candida, it is defined from the Latin toga candida, which is white robe, which was wear by the Roman tenators, and albicans is mainly to white, and that's the reason how the name has derived for the Candida albicans. As you have seen before, there are many species, but the Candida albicans is the most prevalent form of Candida organism in the oral cavity. So it exists in three forms, that is pseudohyphae, yeast form, and chlamydospores, and reproduces by asexual budding, forms a pseudohyphae, and grows rapidly, as we have seen before, in 35 degrees to 25 degrees centigrade. So these Candida albicans, though it is mainly pathogen, the Candida albicans is a normal component in normal microflora, GI tract, and many vagina. And 30 to 50% of the people, most of the people carry the Candida albicans in their mouth, and the rate of this carriage of this Candida albicans mostly increases with the age. So there are three general characteristics where the clinical evidence of infection of the Candida albicans mainly exists. That is based on the immune status of the host. Either the immune status is low or mainly high, oral mucosal environment, how the mucosa of the oral cavity is, and again what strain of the Candida is mainly causing the infection. So the most predisposing factor, like as we have seen before, Candida albicans is a normal commensal organism in our oral cavity. So the change from this harmless commensal existence to pathogenic state occurs followed by certain altered environment in the oral cavity. This can be due to weakening of the host immune system. So there are a lot of local systemic factors which mainly causes this decrease in immune factor system, and also there can be a superimposition of both local factors and superficial factors. Now coming to the host factors, these are important for the development of the disease state. So there are certain host factors, systemic factors and iatrogenic factors which causes the disease to develop in the humans or persons. So the local host factor that predisposes to oral candidiasis is mainly mucosal barrier, saliva and phagocytes. Now in mucosal barrier, we have in oral cavity we have a mucosal barrier which mainly protects the infection to come. If there is a break in mucosal barrier, the candidal organisms can go inside the oral cavity and cause the disease. Again, saliva, the rate of saliva in certain diseases, the rate of saliva decreases. Even then, the Candida albicans can become pathogenic in the state, and also the phagocytes, which are mainly the immune defense system. If their phagocytes becomes less, again the immune status will go down. Some systemic factors that predisposes for oral candidiasis are immunocompromised individual, consisting of many, if they are suffering from diabetes, candidiasis, HIV and candidiasis, leukemia, lymphoma, altered nutritional state, iron deficiency, vitamin deficiency, all these things can predispose to get the oral candidiasis in the patient. And iatrogenic factors such as if the patient is having or treated by antibiotic therapy or corticosteroid therapy, cytotoxic therapy, radiotherapy, cigarette and tobacco smoking also causes the person to suffer from mainly the candidiasis. Now the main pathogenesis of oral candidiasis, the transition of a normal Candida albicans, that is because of the commensal state in the normal oral cavity, to pathogenic is complex, involve lot of mainly predisposing and candidal factors that are local factors such as many denture wearing, if the person is wearing the denture, if they are using steroid inhalers, and reduced salivary flow and high sugar intake also causes the increase in mainly the evidence of candidiasis. And systemic, as we have seen before, nutrition deficiency, diabetes, immunosuppressions causes the candidiasis to occur. So mainly the phenotypic switching, if it occurs, like change in the colony appearance of Candida albicans, the morphological transition forming the unicellular budding cells and many filamentous cells, ability to adhere to many certain dentures or in whatever oral cavity, and presence of many cell immunomodulants and many production of certain extracellular hydrolysis which mainly helps in binding to many the oral surfaces. Now coming to the classification of candidiasis, the human Candida mycosis are classified as systemic and superficial. Superficial is again classified as genital, dermal and ocular. This is the systemic or superficial candidiasis. But because we are dealing with the oral candidiasis, the classification of oral candidiasis was first given by Sabanaiki in 1991, which was again modified by Excel in 1997. So classified under primary and mainly secondary. Primary, they are classified as an acute form and many chronic form. Acute, they are further divided in pseudomembranous candidiasis, erythematous candidiasis. Chronic form as hyperplastic, nodular, plaque-like erythematous and pseudomembranous. Candida associated lesions are present which are denture stomatitis, angular cheilitis and medial rhomboid glossitis. And keratinized primary lesions which are superimposed with the Candida are leukoplakia, lichen planus and lupus erythematicus. There is a secondary oral candidiasis which is local or oral manifestation of the systemic mucocutaneous candidiasis, result of disease such as many either thymic aplasia or candidiasis endocrinopathy syndrome. Now coming to the main clinical features of Candida albicans, these are variety of clinical manifestations making diagnosis very difficult, and infections range from the mild to many severe and fatal, that is disseminated. The first is pseudomembranous candidiasis, very important type of candidiasis. Most common is also called as thrush. Occur at any age. They can occur at deliberated chronically ill patient, infants, or impairment of immune system. These are also seen in healthy individuals if they are either taking corticosteroid therapy or they are suffering from mainly HIV. So oral lesions clinically, these appear soft, white, slightly elevated plaques seen on the buccal mucosa and mainly tongue, palate, gingiva and floor of the mouth. The most important thing is these resemble milk curd or cottage cheese appearance. So these are easily wiped away, leaving relatively normal mucosa or sometimes erythematous area. So if the bleeding occurs, mucosa can be affected by either lichen planus or cancer chemotherapy. So these white plaques, which are mainly present, which are easily scraped out, consist of tangled masses of fungal hyphae, keratin, fiber, necrotic debris and leukocytes and many bacteria. So what were the main symptoms is patient will be suffering from the mild or burning sensation of oral cavity of unpleasant taste and described as many salt or many bitter appearance. So in the severe cases, there will be entire oral cavity will be involved and concomitant involvement of oral cavity and esophagus is seen in many HIV patients. The second candidiasis is erythematous candidiasis. It's also called as antibiotic sore mouth or acute atrophic candidiasis. And it's called as antibiotic sore mouth because it was mostly seen in the patients who are taking antibiotics, and name given as acute atrophic candidiasis as because acute is it like acute form, atrophic, there is a lot of atrophic epithelium which is seen in the candidiasis. So the antibiotic sore mouth erythematous candidiasis has this central papillary atrophy of the tongue is seen, which is asymptomatic, in which symmetrical erythematous lesion of the dorsal aspect of the tongue is mainly lost in the posterior region. There is also chelocandidiasis which is seen in the vermilion border and the perioral skin. So usually these erythematous candidiasis occur as sequelae for the broad spectrum of antibiotics and corticosteroids and any disease which suppress the immune system. Obviously it is erythematous candidiasis, so it appears red rather than white in color. These also resemble pseudomembranous wipe where the white membrane can be easily wiped off, and redness is mostly seen due to increase in the vascularity in the area. So when coming to the differential diagnosis, we need to distinguish from the erythroplakia, which resembles the same as many erythematous candidiasis, although the clinical features and the habits will be different. But clinically the erythroplakia will be having diffuse borders, while erythroplakia will be having diffuse borders, and erythroplakia will be having sharp borders, and erythematous candidiasis will be having the diffuse borders. So it occurs at any site, but it is mostly very painful rather than which has burning sensation seen in pseudomembranous candidiasis. And that's the reason why patient often complains with many, feels as if hot beverage has mainly scalded his epithelium. So the erythematous appearance will be mostly due to many loss of filiform papillae on the tongue, which causes the reddening, bald appearance in the tongue. Next is chronic hyperplastic candidiasis. It is also called as candidal leukoplakia, where the white patch which cannot be easily scraped, which was seen in erythematous candidiasis and pseudomembranous candidiasis, where the white patch can be easily wiped off. It is the least common form and may represent candidiasis which is superimposed on the pre-existing leukoplakia. If the patient is having leukoplakia, if it is superimposed with the candidiasis, it is called as chronic hyperplastic candidiasis. So chronic discrete varied lesions are seen. These mainly vary from small, palpable, translucent, whitish areas. These can be large, dense, opaque, which are seen as plaques, hard and rough to mainly touch. So these are homogeneous areas or speckled areas are seen which do not rub off, such as mainly same as leukoplakia, and occur on lips, tongue and cheeks. These can be seen in middle age or mainly above. Lesions mainly resolve after taking antifungal therapy. So keratotic lesions which are superimposed by candidal infections are leukoplakia, lichen planus and lupus erythematosus. Now coming to the candida associated lesion, the three lesions which are candida associated lesions are median rhomboid glossitis, angular cheilitis and denture stomatitis. Coming to median rhomboid glossitis, it is another form of erythematous candidiasis which is seen asymptomatic, which the central papillary atrophy of the tongue is seen, or median rhomboid glossitis. Initially it was thought as many developmental defect, not anymore. These are symmetrical erythematous elliptical rhomboidal posterior dorsal surface is seen and is again asymptomatic. Erythema is seen because there is an atrophy of the filiform papilla, just like erythematous candidiasis. Occasionally there can be hyperplastic exophytic or lobulated appearance. There will be strong relation between the lesion, candida and mainly smoking. So infected cases may demonstrate the midline soft palate edema in the area of routine contact with the underlying tongue involvement. So this is normally called as many kissing lesion. Some patients with central papillary atrophy may also exhibit signs of oral mucosal candidal infection on the other side. This is called as chronic multifocal candidiasis. Other sites which can be affected with candidiasis are mainly angles of the mouth and junction of hard and soft palate. Coming to angular cheilitis, also called as Perliche angular stomatitis. This is multifactorial, which mainly affects the angles of the mouth, and these are erythematous and many fissure areas will be present in the angle of the mouth. The clinical diagnosis is arrived when we need to rule out certain other lesions which are also seen in the corner of the mouth. That is, we need to rule out recurrent herpetic labialis, ulcerations due to certain trauma and environment exposure or due to many syphilis. So it's been associated with several other predisposing factors such as infections, such as nutritional deficiencies, reduced vertical dimension of the mouth seen in many old age, and in the long-term denture varus. So in the long-term denture varus, that is in the old age, what happens is there will be reduced vertical occlusal dimension with deep skin folds in the areas, and due to saliva accumulation, chronic moist environment will be seen and leads to many predisposed to many formation of this infection. Symptomatic, there will be feeling of dryness and many burning sensation in this area. Severity of many wax and vein presence and loss is seen. Nutritional deficiency of many vitamin D and folic acid is mainly seen, which is important ethological feature for many Perliche, and it is also associated with the Candida albicans or species and Staphylococcus mainly aureus. Infrequently, Candida infections can also involve the perioral skin, usually secondary to the actions that keep the skin moist and creating the clinical pattern known as many cheiliocandidiasis. Next is denture stomatitis. It is also called as mainly denture sore mouth, and in some it is also called as chronic atrophic candidiasis. So mucosa in contact with many fitting surface of the denture, and it has a diffuse erythema or edema of the denture bearing area. Frequently is asymptomatic, normally denture varus, and complaint of slight soreness or burning sensation in the area where the denture is mainly placed. So some studies it is seen as women are more seen in than many the men, and mandibular mucosa are mainly rarely seen, so it's mostly involved in the maxillary mucosa. Controversy, they say that it is actual infection or tissue response to host to various microbes which are mainly present beneath the denture. Clinicians should rule out the possibility of improper denture design. We need to see first denture design, allergy to denture base or many inadequate in curing. Then we need to think about the candidiasis. So secondary oral candidiasis are further classified as chronic mucocutaneous candidiasis, chronic localized mucocutaneous candidiasis, candidiasis endocrinopathy syndrome, and chronic diffuse mucocutaneous candidiasis. Coming to this chronic mucocutaneous candidiasis, the chronic is long-term part of candidiasis. So it is a severe oral candidiasis seen as a component of relatively rare group of many immunological disorder. An immune problem usually arises due to first few years of age, and patient begins to have candidal infections of mouth, nails, and mainly skin. So the oral lesions, in these lesions appear as thick, white, non-scrapable many masses, and these patients will be evaluated, should be evaluated periodically with endocrine abnormalities as well as iron deficiencies, because these are very easy to develop in these patients. And endocrine abnormalities may include hypothyroidism, hyperparathyroidism, Addison's disease, and diabetes mellitus. These endocrine abnormalities develops between months to a year after the onset of many candidal infections, and infections remain superficial, does not disseminate to other parts of the body. Oral lesions and cutaneous lesions can be controlled by use of many systemic antifungal drugs. Second is chronic localized mucocutaneous candidiasis, which is many localized to one certain part of many the body. So it is a severe form of disease which is mainly seen in the early stages of life, and there is no genetical transmission. It is widespread skin involvement and granulomatous and horny masses on the face and many scalp are seen. Increased incidence is seen in many fungal and many bacterial infections. The mouth is a common primary site, and nail involvement can also be seen. Next is candidal endocrinopathy syndrome. It is genetically transmitted condition, and infection of skin, scalp, nail, mucous membrane, classically oral cavities are involved. Association is seen with hypoadrenalism, hypoparathyroidism, hypothyroidism, ovarian insufficiency, or mainly diabetes mellitus. Lastly, chronic diffuse mucocutaneous candidiasis is very least common. Late onset is seen here. Extensive raised crusty sheets are mainly seen in the body, and there is no familial history for this, and clinical appearance of oral lesions are similar to chronic hyperplastic candidiasis. Lastly, we need to know what is an ID reaction here. It is a patient with chronic candidiasis or candidal infections develop secondary skin response to many candidiasis characterized by certain localized generalized sterile vesicular papular rashes that is believed to be in allergic response to many candida antigens. Thank you.